everyone. Welcome to ResearchMD.com. My name is Pramil Cheriyath. I'm a program director in internal medicine residency, transitional residency in the United States. I'm also director of research and assistant professor of medicine to large medical schools. We've been doing a series of lectures on endocrinology. We started with a nutshell, all the hormones. Then we talked about the posterior pituitary hormones. And today we're going to start with the anterior pituitary hormones. And our topic is today is prolactinoma. Okay, thank you for joining us. So let's start talking about. Let's teach you everything about prolactinoma. Very, very important disease. Most common type of secretory pituitary tumor. And then the next thing is a classification. You need to know what is microadenoma, what is macroadenoma. Very, very important. Okay, the size is important. What is the number? Somebody tell me. Less than 10. So remember, 10 is a magic number. If it is less than 10, you call it like microadenoma. And if it's greater than 10, you call macroadenoma. Why is it important? Because most people, some of this microadenoma can remain asymptomatic, or you don't need to treat it if it's not very bothersome. But all macroadenoma, pretty much you have to treat it. Okay, very, very important. Now let's look at the epidemiology, more in females, and then you got associated with in the hereditary form, men type 1 syndrome. Even though it's rare, they can be affected in the hereditary format. Now let's look at the clinical features. So first thing, what happened in the females? There's increased prolactin. They can have galactorrhea, which is the milk hormone. Of course, it has to produce milk because all the breast tissues. What happened in the male? They don't have that much breast tissue, so it's very rare they can have galactorrhea. Remember that. Number one. Number two, decreased LH and FSH. So what happened? You can have amenorrhea, right? Reproductive problems and infertility that comes in. In male, we know if the LH usually simulate what? Leydig cells to produce testosterone. So what happens if you don't have LH and FSH? You can have decreased testosterone. It's very important to know that, okay? And then you got decreased testosterone, that decreased libido in both male and female. In the male, more likely, like a lot of erectile dysfunction, infertility, gynecomastia, osteoporosis, and decreased facial and body hair, and all of this could be causing. And then finally, like in females, there's decreased estrogen that will lead to atrophic endometrium, and then you got vaginal atrophy and osteoporosis and all that problem. So in a lot of problem, but depends upon all the hormones kind of affected. Okay, so let's look at the physiology and pathophysiology together. Very important picture right here. We got our hypothalamus, we got the posterior pituitary and anterior pituitary, right? Everybody knows this is an anterior pituitary hormone, right? And what is it? Prolactin. You got a tumor right here, right? And that's what I mean. Let's look at the physiology. Usually, what happened is dopamine is the master controller. It's under the tonic inhibition of the dopamine, prolactin, right? So constantly inhibiting the prolactin, so not much prolactin is released, right? And then what happened in the hypothyroidism, what happened, you got TRH, increased TRH, right? That can stimulate the anterior pituitary, and you can have increased prolactin. That's a normal situation. I mean, you can say an abnormal situation. Like medication, that can affect the dopamine, and then chest wall injury, nipple stimulation, all of them can cause dopamine, that can increase your prolactin also. Okay, now renal failure and renal failure can have decreased prolactin elimination, so that can also increase the prolactin level in the blood. So when you have like a tumor, definitely there's increased prolactin. What does it mainly affect? The GnRH. It inhibits GnRH, right? So you can have decreased LH and decreased FSH. The main thing kind of happening right here. And always remember some of those medications we have to know. Antidepressant, antipsychotic, metoclopramide, verapamil, opioids, H2 blocker, proton pump inhibitor, and all of this can cause prolactin level to go up. So before you order prolactin test, or when you order a prolactin test and come back high, always think about the medications first. Remember that. Okay. Now, let's look at the next one. Now, what kind of investigations we have to do? First, you always check the prolactin, okay? When you check the prolactin, even if the result is between like 50 to 200 level, make sure you repeat it. It's very important. A lot of times you can have spurious results, and sometimes even you have very high, there's something called hook effect that can, in that case, you have to do a dilution test to make sure you get a correct results. Now, and if it is greater than 200 nanogram per ml, then you pretty much know there's like pituitary adenoma is going on. Prolactinoma is there for sure. Pregnancy, rule out. That's the most important thing. What happened in the pregnancy? prolactin goes up, right? In lactating women, until like the 6 months, the prolactin level goes up. Remember, that's the number one. And then we talk about what? The renal failure and the hepatic failure. So make sure the patient renal function, hepatic function is okay also. We also talk about the hypothyroidism causing TRH and increased stimulator prolactin. So we need to make sure, check the TSH and T4 to make sure there's no hypothyroidism, okay? And then you order a test. Make sure, just don't order an MRI of the brain. Make sure you write the order down. MRI of the pituitary with and without contrast, my friend, okay? Let's talk about the treatment. Again, remember, if it is microadenoma, most of the time you don't need to treat it, okay? And the number one thing always to make sure the offending drug, right, that to be stopped. We talk about the offending drug here, 90% antipsychotic, metoclopramide, verapamil, opioid, H2 blocker, PPI, and all of this need to be stopped. Number two, treat the underlying causes, right? We talk about the thyroid, renal function, hepatic function, treat that correct first. Okay, and then what are the other indications, like, medical treatment? What are the medical treatment? What are the drugs we use? We use cabergoline, okay? What is the other drug we use? Bromocriptine. This is the mainstay of the treatment. Remember that. So if you have to, don't pick the surgery like right away. So the medication drug is the mainstay of treatment. Always remember that. And then that is cabergoline and bromocriptine. So when do you treat the medical treatment? You have to make sure there is macroadenoma, you always treat. There is like enlarging microadenoma, you treat. There is like hirsutism, infertility, galactorrhea, gynecomastia, testosterone deficiency, oligomenorrhea. In all of the situations, you have to treat with the medications, okay? Cabergoline and bromocriptine. Now, indication for surgery, again, that's the last minute option. You got increased tumor size despite medical therapy, and pituitary apoplexy, dopamine agonist resistant, and medically unresponsive. And even the patient, let's say if you have a psychiatric patient, you cannot use, some of this dopamine agonist, then you have to go with the surgery. You don't have any other options, okay? So let's summarize all over again, like one more time. Make sure the magic number 10, microadenoma versus macroadenoma, right? And most of the prolactinoma, remember, they're microadenoma and they're usually benign, and you know how to treat it, right? And then you talk about, in hereditary can I associate with the Men-1 syndrome, sometimes some board examination can ask. And think about the symptoms in females. There's increased prolactin, that goes galactorrhea, increased LH and FSH. You can have primary and secondary amenorrhea, infertility. In male, LH, decreased LH causes decreased testosterone. When you have decreased testosterone, decreased libido, erectile dysfunction, and all of this problem, and decreased estrogen, atrophic endometrium, and vaginal atrophy, and osteoporosis, okay? And now let's look at our pathophysiology up here. What happened? Where's the tumor? Anterior pituitary, increased prolactin, GnRH is inhibited, and then decreased LH and FSH formation. That is the main thing happening up here, right? And then think about the medications, antidepressant, antipsychotic, metoclopramide, verapamil, or even opioids. A lot of people are on opioid now these days. And investigation, make sure prolactin level, but make sure you repeat it. Think about the hook effect. If it is greater than 200, most likely it's like a prolactinoma. Make sure you rule out the other pregnancy, lactation, TSH, T4, renal function. All this need to be ruled out. And then make sure when you order an MRI, just don't write MRI of the brain. MRI of the pituitary with the contrast and non-contrast. And treatment-wise, stop the offending drug, treat the underlying causes. And there is the two main drugs we have now, cabergoline and bromocriptine. The indications are given here. And then the last minute option is surgery if anything doesn't work, the surgery. Thank you so much for watching. We'll be back with another presentation soon. Thank you.